Another thing is these folks have such emotional pain that sometimes they'll cut to distract themselves physically. They'll have physical pain now, so they don't have to worry about the emotional pain as much. I'm trying to think of another thing that it seemed like there was one other thing that a patient told me one time as to why she cut. I'm blanking on it now, but anyways, those things are kind of common. Those things I just mentioned. So it isn't always that they want to die. I guess that's the gist of that. Suicide actually is completed in 8 to 10% of these folks, so it's kind of a high number. And again, it's certainly I'm sure some of them really meant to die, but a lot of them didn't mean to, and it was sort of an impulsive act, and they didn't really think through what was going to happen when they did this. Maybe they planned on spouse coming home at a certain time, spouse didn't come home at a certain time, and they didn't make it, because of an overdose of Tylenol or something like that. Incidentally, this is not, well, these folks come into treatment a lot because of this kind of stuff, right? So they go to the family members, see somebody cutting themselves or taking an overdose of something or threatening suicide, they're going to, boom, they're in the hospital, right? They're at least in the ER and then evaluated. So these folks come to treatment a lot. They don't tend to be hidden, behind the scenes or anything like that. Anybody ever heard of dissociation? I know some of you guys have heard of dissociation. You guys know, any idea what dissociation is? Anybody know? It's the way I describe it is where the person is a little bit, they're detached from their environment. So remember I told you these folks don't feel real? That's a sort of, it's called derealization, and it's a form of dissociation. Sometimes, like I said, these folks will cut because of that, when they feel that way. Oh, I know what the other reason they cut. I saw it here. The other reason they cut sometimes is because they feel that they're bad people. They don't feel good about themselves at all, so they're kind of punishing themselves. So sometimes that's another reason that they'll cut on themselves. Now their moods are they change rapidly, and here's a common problem diagnostically right now with psychiatrists and therapists is that a lot of folks with borderline personality disorder are getting diagnosed as bipolar disorder. There is a kind of a controversy in the field about this. And remember I said personality disorders aren't as as well understood as some of the other things. And so when you look at it on the surface, these folks look like they might have bipolar disorder, right? Their moods change dramatically, up, down, right? The difference is they don't tend to get fully manic usually. And sometimes they don't get as depressed. Not always. Some of them can get very depressed. But the other thing is their moods change dramatically quickly. Moment to moment. 1 minute happy, next minute sad, next minute angry, going to rip somebody's head off. That kind of thing. Next minute they're fine. Quick like that, okay? Now if you think about it, bipolar disorder has mood swings too, but those tend to be a little bit longer. At least days. They're not typically, minute to minute, so at least days. But if you think about it in the brain for a second, there's a part of your brain that controls your moods. And when you when you go from one mood to another, it could be the same part of the brain, and maybe this borderline personality disorder is some form of bipolar disorder. The problem is that it doesn't respond at least the same way that to medicines and treatments as bipolar disorder does. Bipolar disorder, we have very good success with medications and with treatments to even the moods out. With borderline personality disorder, we don't tend to. We can try, we can help some, but it's not as effective. Anybody have questions about that? It seems like some of you people are looking at me kind of quizzingly. No? Okay. These folks, the folks that have borderline personality disorder, they get kind of feeling empty, feelings of emptiness, inappropriate and intense anger. These folks get angry fast, man. Over little stuff. They're ready to rip your head off. Throwing chairs, they just kind of can get pretty violent. They get paranoia, but it's not delusional. It's more mistrust of other people. They don't trust folks. Oh, they're talking about me. I just know they are, that kind of thing. They can experience some types of hallucinations, but they're not typically like schizophrenia type hallucinations, not as odd and bizarre and things like that. But sometimes they will have some sort of pseudo-psychosis is what I call it, what a lot of folks call it. The other thing that's tough is they'll present to a doctor like one way the first time they get seen, and then the next time they get seen and present a different way, and the doctor's thinking, okay, well, they're depressed. Well, they sort of look a little manicky. Well, now they look a little bit anxious. Next thing you know, they're on like 6 or 7 medications, and the doctor really has no idea what's going on. But if he steps back a second and thinks about it, maybe it's borderline personality disorder and it's been missed. That's happened a lot in my practice. I saw that a lot. And the problem with that is that I think it sends a message into the person that there is a medication out there that's going to fix me. And unfortunately, there's usually not a medication that's going to fix them. These folks have eating disorder problems, substance abuse problems. We talked about that. 75% of these folks are female, believe it or not. And then again, like we talked about, childhood histories of abuse. A lot of them have it, but not, you don't have to have it. It's present in about 2% of the general population, but when you go into a hospital setting or a clinic setting, it's about 20% of folks that are in treatment. So that's kind of gives you some evidence as to, like I said earlier, these folks get treated a lot, get into treatment a lot. Genetically, there is a risk as well. 5 times higher risk if you have a parent with this, that you might have it, that a child might have it of that parent. Interesting thing that I think about. I mean, I always try, and you guys too. I think I should challenge you guys to think about these things. Where this could come from in the brain, or what does it look like? Does it look like anything else that goes on, like normal development-wise? But these folks look a lot like adolescents, right? Mood swings, kind of angry. They're indestructible, impulsive, all these things. And so I kind of wonder to myself, anyway, whether this is some type of adolescence gone wrong or something, where they don't form, the brain doesn't, there's a lot of pruning of nerve cells that goes along in adolescence. And maybe something goes wrong or doesn't get finished with that or something. And these folks end up with these symptoms all the way through, They tend to get a little bit better as they get older, less impulsive and such. So maybe the brain eventually catches up and prunes itself. There's a good book about this. And the title alone, I had one patient come to me one day and say, Doc, I was walking by the bookstore and I saw this book and I thought, that is me. And the book is called I Hate You, Don't Leave Me. Okay? Most folks, like a lot of times when I'm seeing somebody and it's the first session, let's say, and I sort of hesitate about diagnosing somebody with a personality disorder in one session because I just barely met them. So I tell them, go get this book and see if I have a suspicion this might be this. And they go get the book and they read it, and if it's what they have, they tend to go, wow, that is dead on, that is me. And so if you know anybody that has it, or if you're interested at all, check out that book, get the library or something. It's just a little paperback, it's not very big. But it talks about all the symptoms that we talked about and a lot of that. Psychotherapy is something, that's usually the mainstay of treatment, but again, it's hard to get folks to stick with that because of the whole relationship thing. Psychotherapy is a relationship. It's a pretty intimate relationship between two people, and these folks tend to feel like they're being abandoned if the person's late or goes on vacation or things like that, and it can be kind of hard to keep them in therapy. Medications can be effective, and they're more sort of symptomatic medicines. I mean, they're things to help with symptoms. So to maybe lower the impulse problems, maybe lengthen their fuse a little bit, that's what I call it. Some of the same stuff you can use for bipolar disorder, like Depakote, antidepressant medications and such. You got to be careful with anything addictive because they're impulsive and they'll tend to get hooked on stuff pretty easy. So I think we're going to stop there. There's narcissistic and there's a bunch of others on here, but we'll talk about those next time because there's no way. It's already been an hour, believe it or not. So does anybody have any questions? I shouldn't say believe it or not. You guys are probably saying, God, it seems like it's been 2 hours. No, you guys have been a great audience. But anybody have any questions about anything? Yeah?
What was the name of that book again?
It's called I Hate You, Don't Leave Me. And sort of describes, you remember what I was saying early on about, they want the person close to them, and they don't want them to leave them, but yet, I hate you, get away from me. So it's that push-pull thing, and that really causes a lot of trouble in relationships, unfortunately. If you're on the receiving end of that, Any other questions? Thanks, guys. I appreciate everybody coming. There'll be one more this year, and then the next I guess in September is when I start